Sitting in a doctor's office trying to understand medicalese is familiar for most of us. That's really frustrating.
Okay. I'm just trying to understand, like, in making this calculation, so, like, I have these lower levels. The longer my body works under those conditions, the more likely something bad is to happen to
I
me.
mean,
Like,
I can't say what might happen. I'm just saying what I'm seeing now. Your compliments were normal in October.
Let's say the doctor recommends a certain treatment. If the patient says no or even asks questions, they can be accused of combativeness or just totally dismissed.
Okay.
So, but if you don't want to, if you don't want to take it, then obviously I can't force it.
No, I'm not saying I don't want to take it. I'm just trying to better understand how to make this decision based on, because, I'm 36 years old. I could theoretically be on this medication for the next 40, 50 years.
It's hard to know how to talk to doctors as everyday people. I mean, we're not the experts about medicine, but we are the experts on ourselves. We live with what we choose and do not choose.
Honestly, I think, okay, this is what I would suggest. I can see that you're really nervous. You can see another rheumatologist and get a second opinion and see what they think.
It's not even like I'm not crying because I'm nervous. Sorry, I'm crying because I'm frustrated because thank you. For me, it's like I'm not trying to be combative. I'm just trying to understand. And I feel like for me, it's very frustrating when you're just immediately like, oh, well, fine, just don't do it.
From Virginia Humanities, this is With Good Reason. I'm Sarah McConnell. Today on the show, talking to healthcare providers. Suzanne Makarem is a professor of marketing at Virginia Commonwealth University. A few years ago, she declined medication that a doctor offered her. When she cried, the doctor recommended antidepressants. Suzanne began wondering how other women deal with their doctors not listening to them. So she did a study. She found 40 women who pursued other kinds of complementary care providers to fill in the gap of being unheard at the doctor's office. She was shocked to find that many of these women now only use their traditional doctors for blood tests, vaccines, and annual checkups. Suzanne, you interviewed about 40 women who started going to non-traditional doctors rather than conventional doctors. Why did they switch?
Well, there were many reasons for switching, but it starts with not being happy and not feeling that the conventional doctors are meeting their healthcare needs. But we wanted to delve deeper into that, to look into the whole experience. How does it feel to be in the parking lot waiting to see a conventional doctor? How does it feel when you leave the office? How does it feel when you're waiting for an hour to see the doctor for only 10 minutes, and how they talk to you? So there's a lot of layers that make the experience with the traditional doctors very dissatisfactory, very stressful. Some of them even describe that they feel panic waiting in the parking lot because they're asking themselves, is the doctor going to listen to me? How long am I going to wait in the waiting room? Is the doctor going to even sit on the chair while they're talking to me? Or are they just going to be standing at the door in and out? And they're thinking, oh, they're going to just prescribe me a pill and tell me to go take the pill and leave. And so the whole experience is stressful for women. And after a while in the traditional healthcare system, many of them are sick of the treatment that has condescension in it and that has a lot of feeling of being unheard and unseen, talked down to. Many of them say, like, we feel brushed off. We feel like we're 1 in 1,000 patients. And so I think all of these cumulative experiences make it so that women are not happy with their traditional doctors and they start seeking alternatives.
Share a couple of the stories that they told you that had led to that feeling of anxiety in the parking lot before you go in.
So there was this one story that stands out to me where this woman didn't feel well, and she was overweight and went to the doctor and always felt this condescension, but the doctor never told her that she's overweight. And then she looked at her doctor's notes, and the notes said, "Patient is morbidly obese." And the woman was like, I was so mad. How are you going to check off that I'm morbidly obese on my chart, but not say anything to me? Like, don't you think this is something we need to talk about and resolve? Sometimes it's that one small experience that breaks everything. And they're like, okay, I'm not coming here anymore. And so this one woman had that experience being in the system for so long. And once she went to an alternative provider, where this type of alternative provider did muscle testing. And she was describing that procedure to us, how this muscle testing works, and saying, I know it sounds crazy. I know this is out there, but I just lost 40 pounds in 3 months. I feel so much better. I was about to be on disability, and I'm the happiest I've ever been. And so those types of experiences are things that we've seen where it pushes women to an alternative that they haven't even considered, that they thought about as sometimes even referred to as crazy, but then that makes their quality of life much better. There's this other woman that the doctors didn't necessarily know her diagnosis. And she was the one who was like, they will never listen to me. They think I'm healthy. They do these blood tests, and the blood tests are normal. So they tell me I'm healthy, but I knew that something is wrong with me. And so first it was her description of the stress that she feels in the parking lot before going to the conventional provider, and that idea of, will they even listen? How condescending will they be? And then she shared that she tries to look worse when she goes to her medical providers to be taken seriously, because if she looks too healthy, then the provider will ignore all the symptoms and all the things that are wrong with her. Another woman who also had been dismissed for a long time and felt unheard, saying that something is wrong, was diagnosed with cancer a year later. And thankfully, she's in remission. When she interviewed us, she was in remission, and she was sharing that she never trusts a conventional doctor anymore. I mean, she had to use conventional oncologists to deal with her cancer, but for her day-to-day care, she completely relies on her alternative provider.
Did you personally relate to the stories of these women? Had you had such experiences yourself with conventional medicine?
Definitely, I related. During that time, I was in the office with my gynecologist, and she started talking down to me, and I felt very unheard and talked down to. And she raised her voice and started telling me that I don't want to help myself because I'm questioning the birth control she wanted to put me on at the time. And I started crying, and she was like, well, you don't want to help yourself. What I can do for you is prescribe antidepressants since you're this emotional. And I couldn't believe that I was having this experience and I was thinking, like, I'm somebody privileged in the healthcare system. Like, how do more vulnerable people feel when they interact with doctors and they're treated that way? And of course, I left the office and never came back again.
So if the women were frustrated by their experience with conventional medicine, how did they turn to alternative medicine? Why didn't they just go to another more sympathetic traditional doctor?
It takes a point of desperation sometimes to get to consider an alternative for some of these women. Now, some of them come with beliefs and cultural background that makes them more open to complementary providers. But many of them, it's word of mouth, it's social media, it's their friends, it's their family members, seeing them in distress and telling them, we have somebody who could help you better.
And tell me who we mean by complementary and alternative medicine providers. People like what?
So those are your chiropractors, osteopath, acupuncturists, homeopathic doctors, naturopath. There are also, some of them have integrative or functional training. Some of them are called holistic medical providers.
But don't traditional doctors say, yeah, good luck with that? I mean, they can do some things and they can make you feel better, but can they treat the underlying serious issues?
One of the things we find is that women do not tell their doctors about going to an acupuncturist or a chiropractor or herbalist or homeopath because they're against it many of the times. And most of the time, they don't even ask about it. So it gives women an out to not tell their providers about this. Now, yes, the women do admit that conventional doctors are very useful when it comes to surgeons and specialists. But when it comes to primary care providers, many of them have told us that since their experience with complementary and alternative providers, they've decided to only use their primary care conventional providers for blood tests because that's covered by insurance, for vaccines because that's covered by insurance. So they go to their yearly mostly because they don't have to pay out of pocket, but they don't trust their primary care providers. And I think for primary care, it's harder for those doctors to argue, good luck living without me. The alternative doctors cannot do anything for you.
Tell me a little bit about the women in your sample. This was about 40 women that you found how. Tell me a little bit about them.
We wanted to see whether the stories of white women were different from the stories of Black women, from the stories of Asian women, Hispanic, Latina women. And so we tried to make it so that we have equal numbers of white, Black, Asian, and Latina women in our sample. But in terms of generally what they look like, half of them had a bachelor or postgraduate degree. The other half had high school, some college, or an associate degree. We had representation in terms of Affordable Care Act, private, employer-based, that was half of the sample. But then we had a lot of people on Medicaid and 3 who were uninsured. Similar, we had a good division of income. In terms of age, they were all between 18 and 49. So we wanted those women that are called reproductive age women. And we tried to have equal numbers of women in their 20s, their 30s, and their 40s.
And what did you find were some of the major differences between Black women, Asian women, Hispanic, and white?
So we found that there are a lot of similarities in their experiences, except for Black women's experiences stood out in terms of stigma related to their race and in terms of what they do to prepare for meeting their primary care provider for the appointment. So they would say things like, when I speak with them, I speak differently. So this is the code switching. They dress up. They put makeup on. It's like they're going to a job interview. And they do their research because they believe that they have to show a level of knowledge to be taken seriously or be treated with dignity. So that was a major finding we found for Black women that is a little bit different than all the other women's in our sample.
But you know, I saw my mother do the same thing when she was being seen for serious issues. And I understand that. You want to be taken seriously and respected by your doctor, so the doctor will be invested in your outcome, right? It's a pretty big deal.
Yeah, definitely. It might be something that you see across the board. For Black women, it just was more highlighted. And we saw in relation to that a lot of experiences of stigma. And so people who do experience stigma are more likely to behave that way, to try to look and have the knowledge and look like they're going to a job interview. And we found that women experience stigma not just because of race, but because of their weight, the size of their family. They felt judged if they had too many children. Their sexual orientation definitely came up, and their religious beliefs. So So I think there's that link between feeling stigmatized, no matter what the reason, and the efforts one makes to look better and look professional and have makeup on and dress a certain way and speak a certain way.
What most surprised you about what you found from these women?
One thing that was very surprising is these women started using the word medical, clinical, as something that is negative, almost derogatory, saying that, well, they're very medical, they're very clinical and rigid and close minded and textbook and businesslike. And all these descriptors, and I'm quoting these women saying that about their conventional providers, made them feel that the conventional providers have less skills. And that was very shocking to us because we always thought that at least their view or beliefs about these very well-trained, skilled, board-certified providers would be that they have the skills, but their bedside manners are the problem. But it was beyond that.
How do you think we got to this point? Is it that there is the internet and there's social media? Is it something changing about conventional medicine? What is this?
I think it has to do with both. I feel that conventional healthcare provision can become much better. Doctors can be trained to interact better, if I may say, even if they have very limited time with their patients. Some of these women said things like, oh, my doctor is there 15 minutes, and they felt that it's in and out. And I'm like, 15 minutes is a long time. But it's because they stand by the door or they sit facing away from women, typing on their computers and just prescribing a pill and leaving. So those small changes, like sit facing your patient, can make a big difference. So many women are facing this dead-end solution of take this medication and they know that it causes them a lot of side effects they don't want to live with. So they say, well, no, are there alternatives? And the doctors most of the time come up with dead-end solutions like, oh, no, this is it. If you don't want to do that, you can't help yourself, then I can't help you. And I think they're seeing much more openness and choice and empowerment on the alternative and complementary medical provider side.
Suzanne Makarem, thank you for sharing your insights on With Good Reason.
Thank you so much, Sarah, for having me.
Suzanne Makarem is a professor of marketing at Virginia Commonwealth University. It turns out the United States and New Zealand are the only countries that allow pharmaceutical companies to advertise directly to consumers. So, ever since the late 90s, American cable TV is littered with direct-to-consumer drug ads that urge people to ask their doctor today if a certain drug is right for them. Staci Defibaugh is a professor of English at Old Dominion University. She says these ads are not just promoting drugs to patients, they're also showing people how to be an activated patient. Staci, what was it that first drew your attention to these medical ads that are everywhere nowadays, urging people to ask their doctors for very specific drugs, rather than just waiting for their doctors to offer them to them?
I think just the fact that they were everywhere, right? If you turned on the TV, and still if you turn on the TV, you see them all over the place in healthcare and looking at language in healthcare. I felt like this was something I wanted to dig into a little bit and try to understand a little bit more from a linguistic perspective.
These ads didn't used to exist on TV. At one point, they weren't allowed, and then suddenly they were allowed and the market was flooded with them.
Right. I think it was 1997, the FDA started allowing them, and they're actually only allowed in the US and New Zealand. Every other country in the world does not have these kind of direct advertisements for pharmaceuticals. It started in 1997. I feel like they really gained prominence really in the early 2000s is when we saw them kind of showing up a lot more frequently, and people started talking about them a lot more too at that point.
You've also seen them as ushering in this sort of new era in a relationship between doctors, nurses, and patients that has evolved from I'm the medical practitioner, I know the best, and I'll tell you what you need, to a partnership between the two.
Yeah. So this kind of shift that's happened in medical care from the doctor being the expert and us coming to the doctor to get their expert knowledge to this more kind of partnership. It started happening maybe in the 50s and 60s, and it's evolved ever since and has become much more prominent now, where these are our expectations when we go to see a medical provider, is that they're going to listen to us. There's also an expectation probably that we're going to do some research on our own before we get there. And so that kind of shift in who's the expert has happened alongside the pharmaceutical ads, not necessarily because of them, but I think having these ads on TV does provide this extra piece of information for people going into a doctor. And it also is kind of urging them to act in a particular way. That's the goal of the advertising, right? Is to get patients to want to get these medications, right? And so we see kind of those changes happening at the same time.
What kinds of drugs were being pushed to the viewer, and what sort of conditions were they treating?
They were for lots of different conditions. I found a couple of them for diabetes. The diabetes medicines were things like Invokana, things like Humira for psoriatic arthritis. There's a couple of ones for irritable bowel syndrome, Vibreze, Linzess. So there's pretty wide variety of ads and different conditions that are being advertised to people.
You were looking also at the language being used in the commercials and found that almost all of them tell the viewer to ask their doctor for a specific drug. And it was either a strong ask or a softer ask, depending on the drug in the commercial.
Right, right. So almost every single one of them would have language that either said, ask your doctor about or talk to your doctor about. In both cases, these are commands to tell people what they need to be doing. In a lot of cases, we saw things like today, talk to your eye doctor today, where there's this sense of urgency. Don't wait another day, take it into your own hands and make sure that you're doing this. Some of them were a little bit softer and would say things like, talk to your doctor about Celebrex and see what's right for you or see if it's right for you. So some had definitely more urgency than others. And then they would also give kind of imperatives like, don't take it if you have other conditions, or stop taking it if you notice this. So not just initiating that conversation, but also this expectation that you as the patient need to monitor everything that's happening along with the medication, which is another thing I thought was interesting.
And you found that these direct-to-the-consumer drug ads on TV were sort of reversing the tradition of a doctor noticing that something should be tweaked or addressed in the patient, and the patient coming to the doctor and saying, I've noticed this about me. Let's consider this drug.
Yeah, absolutely. I think there's a shift in where that conversation starts. Does it start in the medical visit, or does it start outside of the medical visit and then get resolved there? It's kind of switching the order of events compared to what we used to do. And then that also kind of switches how we feel as a patient in terms of what we're asking from our provider and what we think the role of the provider is. It's really changing that relationship.
You've also written that it suggests that there's sort of an ideal way to be a patient, and they're presenting these ideal patients in the commercials as people who are aware of their bodies and bringing their concerns to their doctor.
Yeah. This is one of the most interesting things I found. So here's an example from the Eliquis ad. In the ad, it shows a man kind of leaving the hospital, right? And so he says, I had so many thoughts once I left the hospital about a DVT blood clot. What about my life? I was given warfarin in the hospital, but wondered, was this the best treatment for me? That alone is an interesting thing to say. Medical providers gave me a medicine for this condition I had in the hospital, but maybe they don't know what they're doing.
Right,
Maybe
right.
there's something better. This kind of patient who's in the research, people kind of talked about them as being activated patients. This kind of activated patient is what then is being modeled in these ads. And so from there, after he asks this question, he then does some research. He brings up to his doctor this other medication, Eliquis, and then he finds that Eliquis is the answer for him, that warfarin was not. So very much kind of performing this role rather than just speaking to the audience, but modeling for the audience how you should behave.
Do you think the ads are bad for us? Is this just capitalism run amok, or are they also good for us?
I think it's complicated. There is something good about us as patients, as humans with potential like medical conditions, having access to information. I think that's a good thing. I think knowing that there are options out there is a good thing. I think being told or being given the impression that these ads do that we have more control and maybe more knowledge than we think we do is problematic. I think the ads maybe give people a false sense that there is maybe only one medication that's going to work for them, the one that was in the ad. And then when they go see a doctor who has more information and they say, you know what, I don't know that this is quite right for you, then I think it creates this complicated position for the patient and for the doctor. And so while I think the information is good, I think marketing is a bit problematic.
Along the way, did you come to understand just how many of these ads the average American is seeing who's still connected to cable?
Yeah, so back in 2004, researchers looked at it and they found that 83% of people had seen these ads in the past 12 months. And just the sheer amount of them means that we're getting way more health information from these ads than we are from talking to our medical providers, who we may only see a couple of times a year for 20 or 30 minutes, right? But when we're seeing hours of them every day or every week, that really adds up.
Staci Defibaugh, thank you for talking with me and With Good Reason.
Thank you so much for having me.
Staci Defibaugh is a professor of English at Old Dominion University. This is With Good Reason. We'll be right back. Welcome back to With Good Reason from Virginia Humanities. My next guest is Alton Coleman. Alton Coleman is a professor of health sciences at James Madison University. He recently came back from Costa Rica with his students, where he helped them learn that the key to living right is eating well, exercising, and sharing meals with others. Men have a lower life expectancy than women, and Alton thinks that fathers and sons doing more of these things together will lead to better health outcomes for men. Alton, you just came back from taking students to Costa Rica to immerse them in what you call the pure life and to learn the formula for longevity and optimal wellness. What is the formula for longevity?
You know, the formula for longevity is eating right, eating balanced meals, exercising, de-stressing, and really communing with others.
And why was that Costa Rica?
In Costa Rica, we're seeing that the communities are still highly connected with one another. And even though they have a developed economy, they're still very communal, family based, and they still do the things that we used to do, like functional physical activity and eating right and enjoying meals together and laughing together. And so they're experiencing the benefits of those things.
What is functional physical activity?
Functional physical activity is when, what physical activity or exercise you're doing that allows you to work in life, right? Like chopping wood is an example of functional physical activity. Being able, walking up a mountain, walking up a hill, those are functional activities, right? Like it allows you to be able to move in life with the less aid of others or devices.
We don't walk as much as we used to.
No, not at all. Like Americans have become more and more sedentary as time has gone on, especially after COVID when people were in their homes, right? So you could work from home. And now those steps that we used to take to get out the door to get in the car and then those steps from the car to the office, we're no longer taking them because we're just sitting in our home.
It's interesting that you took the students to Costa Rica, and I know there were rigorous classes
Yeah.
there, but it reminds me that when you were younger, you joined the Peace Corps and you asked them to send you someplace remote. You said, I want a remote experience, not an apartment experience.
Yes. I wanted the original Peace Corps experience. I wanted to live in a hut. I wanted to be on the beach. And that's what they gave me. And so I was in the Republic of Kiribati, and I had no running water, no electricity, but I was filled in a community with love. I was able to learn about the culture, the language. We were physically active. We ate healthy, and we enjoyed one another. And so I see those same kind of characteristics of health in Costa Rica. And it was such a wonderful opportunity to take the students to Costa Rica to see those things themselves.
Where is Kiribati and what sort of island is it?
Okay, so Kiribati is a coral atoll. It's in the middle of the Pacific. It's actually, I like to say it's in the middle of nowhere because it is exactly on the equator and 180 east-west. So it is exactly in the middle of nowhere in the Pacific. Sadly, Kiribati is considered to be a sinking island because of climate change. The water level is rising. The coral atoll is not keeping up with it. And so it could be one of the vanishing countries in the world.
Before you joined the Peace Corps and went to Kiribati, you had planned to go to law school.
Yes.
And you actually wanted to be an international copyright lawyer.
Yes.
That didn't happen.
Yeah, no, it didn't. I thought I was going to go and make money working for the golden age of hip hop and R&B. But when I went to Kiribati, I saw how public health has such an impact on people's lives. And without public education, there are going to be health disparities and early mortality. So there was no way once I was there and had experienced that life that I could go back and just wear a suit. I was like, I want to help people and help communities live longer.
What did you see in Kiribati where people were hurt and could have benefited from better public health?
Yeah, the thing that really got me was there was a Roman Catholic catechist who I used to see every day. He would ride his back up and down the road, visiting people, doing ministry. And one day I noticed he wasn't on the island anymore. And I wondered what had happened to him because it was such a small island, you couldn't hide, right? There wasn't no place to hide. And what happened was a couple of months later, I saw him and he had no legs. He had his feet amputated. And when I asked people what happened, they said it was because of diabetes. Those amputations, they're preventable. And I thought to myself, if only I was able to learn more about prevention and then go back and go into communities and teach the communities about how to prevent these deadly diseases.
It so moved you
Mhm.
that you ended up getting your PhD in
Yeah.
this public health, and you wrote your dissertation on obesity in African American and Caribbean Black fathers and sons.
Yes, I'm an African American man. My father is African American, and one of the things that I noticed in our community is the growing number of obesity. Now, what was really amazing is that African American men have one of the shortest life expectancies of any gender or race in the United States. On average, an African American man is expected to die 12 years earlier than a European or a white American female who was born the same year as him. So, what I always tell people is that the Black boy who you went to school with, he's going to die when his grandson goes to kindergarten, and you're going to live to see your grandson graduate from college. That gap in mortality really affected me, and I wondered why were we ignoring this? And that's when I decided, hey, I need to get a degree and try to help the Black community and Black men in particular.
And is that mortality gap mostly obesity?
Yeah, well, what we see is with obesity and complications that lead from obesity, like cardiovascular disease. So, high blood pressure, high cholesterol, diabetes, these things that are comorbidities or side effects of obesity, that they're running like a team, and they have a negative impact on Black men's health.
What's your idea to reverse that?
Eating right, sleeping, being physically active, having a strong community, engaging with others, those are the things that lead to long lives. So, my question is, how do we promote healthy eating? How do we promote physical activity? How do we promote these things for Black men? Because we know it has a deep impact on their longevity.
And how do we?
So, one of the things is creating spaces where African American men feel comfortable being physically active. Because of the way the environments are, there are barriers to African American men being physically active. And this may be that they live in lower income neighborhoods that don't have green spaces like parks and, recreational areas. It may be that they feel uncomfortable going to spaces like state parks or national parks, or they don't have exposure to it, or it may be that they feel unsafe in these spaces. So, for an example, what we have seen in the past in the news is the death of like Tamir Rice, who was a young African American boy who was playing in the park. He had a toy gun that many young boys play with. The police were called on him, and he was killed. Ahmaud Arbery, 22 years old, prime of his life, running in a neighborhood, just trying to be physically active for his health. And then two men felt like he didn't belong there, hunted him down, and killed him in the streets. So these stories affect Black men and how they feel, whether or not they feel safe in these environments. And so what we've seen is that many Black men have decided, I'd rather die a slow death from diabetes, obesity, cardiovascular disease than to get shot in the streets.
Can you relate in any way to a concern that people will perceive you as other?
Yeah, I've moved all around the United States, and I have learned techniques and skills. I think this is something that many people don't realize, the unspoken curriculum that African American men have to learn, and how to make people feel comfortable around you. And so when I moved to Harrisonburg, I remember moving into the neighborhood with my father, who's only moved one time in his life. And after we had moved all the furniture, I told him, let's go outside and sit on the porch and have a cup of tea. And he was like, well, why would we do that? Like, it's hot outside. We could just have the tea inside. And I was like, we have to let people see us in this space.
You mean white neighbors see us?
Yes, we had to allow our white neighbors to see us in this space where they didn't think we were just movers because we moved the furniture in, or they didn't think we were gardeners because we cut the grass and trimmed the hedges. They had to know, like, oh, this person lives here. And so for them to feel comfortable and safe for me being there, therefore I could be comfortable going out into the neighborhood, exercising, running, walking, going to the park. So I had to make them feel comfortable so I could be comfortable.
Were there other techniques you've used?
Yeah, like, one of the things that a lot of African American men do, and I do it as well, is like when we go for walks in the neighborhood, is carrying like a cup of tea or a cup of coffee with us. Because people realize, like, hey, if I see him with this Starbucks cup, he can't be here to try to rob or steal us from us, right? So who is going to break into your house and leave a Starbucks cup? So, it puts people at ease, and then they start feeling more comfortable with you. And then they're more likely to come out and greet you and talk to you and get to know you.
What can we do? How do we encourage African American men and boys to engage in fun, leisurely, physical activities without feeling threatened?
Now, one of the things I would tell people is to acknowledge bias Right. So if you see an African American male or a young boy at a park, do you feel like you're in danger? Do you feel like they don't belong there? And that's a bias that you have towards them. So the question is then, like, instead of acting on that bias and immediately calling the police or clutching your purse or, staring at them to make them feel uncomfortable, if you just said, okay, they belong here just like anybody else, maybe I just say hello. So I would always tell people, show that hospitality in these spaces that we're known for.
What else do you want to say about your desire for Black men and boys and their better health?
We need to start creating opportunity, not just for Black fathers and sons, but all fathers and sons, in which fathers and sons engage with one another. Back in the day, there were times where fathers would throw catch of the ball with their sons, but we're seeing that over time, there's a decrease in this. We're seeing an increase of boys playing video games, so they're not as physically active, fathers working longer hours, so they're not as engaging with their sons. So we need to create systems in which fathers and sons can engage with one another. We want to see fathers role model physical activity in healthy ways and enjoying it, and then sons would then pick up those habits, and we hope that they'll continue on throughout the generations.
Did you have that healthy relationship with your own dad?
Definitely had that relationship with my father. My father was a single parent. I moved in with him when I was 13 years old, and we moved to Georgia, and we did functional physical activity. My father was a builder. My father knew I was afraid of heights. He would put on new roofs, but he would tell me, he was like, son, if you could just bring the shingles to this part of the ladder, I'll bring it the rest of the way. He met me where I was at. He understood my weaknesses and my strengths, and he worked with me. And I think that, that bond, that enjoyment, those childhood memories is one of the reasons why I know that if we can increase those for other African American fathers and sons, and just fathers and sons of any race, that we're going to see healthier men. I talked about earlier that African American men have the lowest life expectancy of any race or gender in the United States, but men in general have a lower life expectancy than women. And this gap started around the 19th century and has persisted and gotten wider in the 20th century. And one of the things I really do believe is that if we can increase the bond between fathers and sons, the enjoyment that they have around physical activity, sharing meals together, talking, communing, the same things that we saw in Costa Rica, those relationships, that we'll see healthier people, healthier men in the United States, regardless of race.
Alton Coleman is a professor of health sciences at James Madison University. Appalachia is a nice vacation spot for some people. For others, it's a beautiful home, but where access to basic needs like healthcare can be extremely complicated. Troy Mackle lives there. He's a professor of biochemistry at the University of Virginia College at Wise. He and a group of pre-med students visited a community in Appalachia to offer medical advice and screenings. But they found out the most glaring barrier to accessing healthcare there is a lack of trust in medical professionals. Troy, near where you live and teach, the Appalachian region of far southwestern Virginia, there's a significant rural population. Would you describe that part of Virginia, what you love and what it's like, what it looks like?
So I grew up in Texas, then I moved to Florida for 6 years to do graduate school, and then I came up to Southwest Virginia. So I felt when I came up here, I was like, oh, it's going to be, the South as I already know it. And that's not the case. It's something completely different. Picture the greenest place you've ever seen in your life. There's so many trees. There are so many, flowering vines, wildflowers everywhere. And it's just the most verdant, beautiful, lush place I've ever been in my entire life. And I tell my wife this all the time when we're driving across the flyover from Big Stone Gap coming back toward Norton. If I ever stop being impressed by this view, you'll know something has happened. I am not myself anymore.
Also, I assume super mountainous?
Oh, absolutely. You kind of have to be a goat if you're going to navigate around here on foot. Our house is built physically into the side of a mountain. A lot of houses that are out here are built that way. A lot of people live in mobile homes or other types of prefab homes, and they're just all over the mountains. A lot of people are living on dirt roads or gravel roads, things that the state can't plow.
How far do you live from where you work at the college at Wise?
So the college at Wise is about 6 miles from my home, but you have to go up a mountain, down a mountain, and then through a series of switchbacks to actually get to our work.
So if you're not teaching at the University of Virginia College at Wise, 6 miles from you, and you don't have independent wealth and you didn't bring your money from elsewhere, how are most people making a living?
So coal mining is still a really common profession around here, even though it is on the decline in terms of the way that economics are going. A lot of people still work in the coal mines. Many people also find work as mechanics. Lots of people work at the grocery stores, the local bank, Tractor Supply, those kinds of things. And if you are not working, let's say, a retail job, and you're not working physical labor, a lot of people are running daycares out of their homes. Many people are working for their churches. A lot of people are trying to pick up shift work wherever they can.
How widespread is poverty, would you say?
I think what the best representation of the reality of poverty in Southwest Virginia looks like is the usage of our food pantry on campus has increased exponentially in the past few years. With COVID, it got really, really bad. So a lot of people were unemployed because they were working retail establishments that couldn't recover from the devastation of the pandemic. Restaurants that had been here for years and years and years shut down. Clothing retailers shut down. We lost a lot of businesses, and people lost a lot of their income because of COVID.
Don't they say about that corner of Virginia that it's closer to 8 other state capitals than Richmond?
That is 100% true. So the east side of the state, which is where all of the military bases and all of those kinds of things are, they make a lot more money than those of us on the western side of the state. We have a serious problem here in that we not only have a growing poverty rate, we also have a growing rate of people that make enough money on paper, but are actually underpaid or underfunded in terms of their living expenses. On top of that, we have the added problem of there are not enough doctors in our region to provide health care to everyone that lives here.
So what does that mean? How hard is it to get to a doctor for an earache or a heart checkup or anything else routine or serious?
So I found a lump in my chest, and my doctor said, "This is concerning. We need to have it looked at by a specialist." Called the specialist at the local hospital. The local hospital is about 15 minutes away from Wise, so about half hour from my home. So I have to drive a half hour to the hospital if I were able to get an appointment. They tell me we are not able to give you a mammogram to check that lump, whether it's cancerous or not, for 6 months.
Oh my gosh.
In 6 months, I could be dead. I could be stage 4. I could have multiple metastasis. That could be the difference between stage 1, surviving, high quality of life, great prognosis, or you're burying me in 6 months. And so from there, when they said, well, if you don't want to wait 6 months to get in here, we can sign you up for a mammogram at the specialty clinic in Kingsport. Okay. How far away is Kingsport from Wise? It's about 45 minutes. So think about this from the perspective of, I have the luxury of being able to take off work without any penalty to go take care of my health. And I have a car that I can actually put gas in and keep operating.
Are you okay? Did you find out the lump is benign?
To finish that story, everything was benign. It was a calcified lump from a previous surgery that I had had. But it really got me thinking about healthcare access in our region. How can I make this better?
What else are you seeing in terms of access to healthcare? What do you see ordinary people having to go through or without?
In Wise County, we essentially do not have public transportation. If you don't have a car, ultimately this leads to a lot of isolation. And it got even worse during COVID because people were sequestered in their homes. They couldn't go anywhere. And even if they could, for example, say, I'm going to go to the store, how are they going to get there?
You and your students are working to alleviate some of these issues, especially in a town called Inman Village that was built on top of a reclaimed coal mine. Tell me about what you're doing there and what is Inman Village?
Usually, if you look at where doctors go after they finish medical school, they go off and train somewhere completely different from where they did their medical education. So that means if you're going to school in Appalachia, you're going to leave Appalachia. So we came up with the idea of a volunteer-based program where medical students would go out into the community, meet people where they are, learn about the limitations and boundaries that they face, and then bring that information back to share with their peers. So ultimately, this worked. It was wildly successful because when they went to Inman Village, they not only met the residents that were living there, but they also met my pre-medical students. So part of my job at UVA-Wise, aside from teaching biochemistry and biology, is to be the program advisor for all pre-professional programs. Anyone that wants to go to medical school, wants to become a veterinarian, a pharmacist, a dentist, any health-related public-facing career, they come through my office. And I get to say, hey, there's a great learning opportunity for you here. Go learn about what our community actually needs. And so one of the women who we had worked with day in, day out, she's like the matriarch of this community. She said to this group of doctors and medical students and pre-medical students, she said, doctors and nurses are a lot like cops and lawyers. You want to avoid getting involved with them at all costs because all they do is bring you trouble. So it's a trust issue. Part of the reason why people don't seek help is financial. Part of it is related to what resources they have. And then her statement hinted at this other undercurrent of an issue, which is that they don't trust medical professionals. That trust is not there. And so in order to, I think, resolve this and ultimately improve quality of life and healthcare access in our region, we really have to tackle that issue of trust.
Troy Mackle is a professor of biochemistry at the University of Virginia College at Wise. With Good Reason is produced by Virginia Humanities, which acknowledges the Monacan Nation, the original people of the land and waters of our home in Charlottesville, Virginia. Our production team is Allison Quantz, Matt Darrow, Lauren Francis, and Jamal Milner. Andrew Rice is our intern. Special thanks to Jenny Taylor for booking assistance. For the podcast or to comment, go to withgoodreasonradio.org. I'm Sarah McConnell. Thanks for listening.